Welcome to Fertilish, the podcast where we get real about fertility, infertility, and everything in between. I'm Laura.
And I'm Brandis. And whether you're knee-deep in treatments, just starting to ask questions, or somewhere in the ish of it all, you're in the right place.
Here we ditch the stigma, break down the science, and have candid conversations about the messy, emotional, and sometimes hilarious journey to growing a family and preserving your fertility.
So grab your coffee, your meds, or just your curiosity, and let's get into it. All right, so we are back for another episode of Fertilish. And this week we're talking about polycystic ovarian syndrome, or PCOS.
Yeah, I think we have, I talk to patients all the time that have been trying to conceive and have either been diagnosed prior to trying to conceive or they were diagnosed like while trying to conceive and having troubles. But I think that PCOS is a huge reason why patients end up needing fertility services. Obviously, not all patients that have PCOS need fertility treatment, but we do have a large number of our patients that are needing fertility treatment that do have PCOS.
Yeah, and I think PCOS, there are so many misconceptions about it. Like, people will go for pelvic pain to the ER and they'll say, oh, well, they found a cyst on my ovary. And a cyst really is any fluid-filled structure. And so, in the menstrual cycle, we really always have cysts. In the follicular phase, eggs are growing inside follicles, which are the little egg houses. And so those are cysts. And then in the luteal phase, you have a corpus luteum, which is that follicle that heals after ovulation and produces progesterone, and that's a cyst. And so it is normal to have cysts in the ovary as somebody who, has a menstrual cycle. And so that doesn't mean you have PCOS. I think the other misconception is, I'm not obese, so I can't have PCOS. Mm-hmm. Or I am overweight, so I have to have PCOS. Or I'm going to need fertility treatment. And none of that is true.
Yeah, absolutely. And, I think that for some reason along the way, some of the symptoms that can happen became synonymous with diagnosis, or diagnosing. So, the, like you said, the weight. So looking at patients that suspected, that are suspected of having PCOS, if they are not of a certain BMI or a certain weight, I think sometimes it is brushed off as, well, no, that's not what the issue is, because, of XYZ, or, the patient doesn't have facial hair, or, there's a number of different symptoms that you don't have to have and don't have to be true for you in order for you to have PCOS, or vice versa.
Yeah. Well, and I, my whole life, have always had irregular periods and acne. And, I also have, peach fuzz on my neck and different places. And I always just assumed, because I was kind of a Spanish descent, that was part of it. But the acne, I used to have it really bad on my back, my chest, my face. And then, like I said, the irregular periods, and I really never thought anything of it, except for when I would go to, for a physical for nursing school, when I was in nursing school, or different things, and they would ask about periods, and I would say, oh yeah, they're irregular, and I would bring up acne, and they would say, oh, do you want to go on birth control? And it was back then, I'm like, no, I'm telling you about my acne. Right. And I don't care that I have irregular periods.
There was no further explanation.
Yeah. Mm-hmm. And I think, there's not always the best job done, which will kind of go through treatment of PCOS, which can include birth control, of explaining why we would recommend birth control. And so I think, that's where the post-birth control syndrome comes from, about, oh, this caused PCOS.
Right.
It masked my symptoms, when actually it was treating it, and preventing things like uterine or endometrial cancer. So I think, that's part of the reason why there's so much confusion about it.
Yeah, I agree. I think that there should be a lot more education to patients who are either suspected of having PCOS or who the provider knows that they have PCOS, and so they're, trying to offer some potential solutions to manage symptoms, et cetera, as to why there's congruency between the two. Why are we treating these symptoms with this particular thing? Because you have this underlying issue.
Well, yeah, and I feel like, like when I mentioned the irregular periods too, it was the birth control and maybe gain weight. And then, I have friends that have been overweight and went for irregular periods, and they did have PCOS, and they got told, well, just lose weight, and they'll probably be right. So, yeah, it's kind of a topic that is not talked about a lot, and people go their whole life without knowing that they have it. But I think in order for people to understand PCOS, it's important to understand how a normal menstrual cycle works. So I usually explain, that you're born with all the eggs you will ever have, and they're kept in a vault. And every month, whether you've gone through puberty yet, whether you're pregnant, whether you are on birth control, a group of eggs will come out of the vault and go into the ovaries. And the more eggs you have left in that vault, the more eggs that'll come out. The less eggs that you have, the less eggs that'll come out. So these eggs get released, and the brain senses that and sends down a hormone called follicle-stimulating hormone, or FSH. That signals to the follicles, which are the little egg houses that the eggs are in, hey, start growing. As they grow, they put off estrogen. Estrogen kind of does two things. It grows the lining in the uterus, and it sends feedback to the brain that, hey, we're growing. Once there is a certain level of estrogen, it's about 200 picograms over milliliter for about 50 hours, the brain says, okay, there's a dominant egg here, a dominant follicle, time to ovulate. And it'll send down luteinizing hormone, or LH, to signal to that egg to ovulate about 24 to 36 hours later. And that's the hormone that we check with those OPKs, or ovulation predictor kits. That egg will go on to ovulation, and the follicle that it leaves behind will heal itself and turn into what's called a corpus luteum. That corpus luteum will be stimulated by LH pulses from the brain to produce progesterone impulses throughout the luteal phase. If you were to get pregnant, that corpus luteum would stay stimulated to produce progesterone from the HCG, or the pregnancy hormone, and then the placenta would take over at about 8 to 9 weeks of pregnancy, and the corpus luteum would die off. If you don't get pregnant, then that corpus luteum will produce progesterone for about 12 to 14 days in the luteal phase. If there's no pregnancy, or it's not rescued by the pregnancy hormone, it'll die off. You'll get a drop in progesterone, and then that's what causes you to have a bleed, and then that process will start over. Which I feel like the menstrual cycle isn't really talked about.
Absolutely.
A lot.
No, I agree. I think that so many people don't have a basic understanding of just what happens with their body each month. I wish that we were educated more as we near the age of starting our periods, our menstrual cycles, or sometime after that, just what is happening to our bodies each month. It's something that most women are going to have to have once a month or somewhere near that for a long period of time. And so I think it's important to know what is going on with our bodies.
Yeah, well, and with PCOS, a key kind of hallmark feature of PCOS is irregular or absent periods. And what's happening, so instead of, a normal menstrual cycle, what's happening is that so many eggs are getting released from that vault every month, but a normal amount of FSH is getting released from the brain. And so when FSH is coming down, and remember, the brain can't see what's in the ovary, it only gets hormone feedback. And so it'll send down this FSH, and that signal gets so diluted amongst so many follicles that nothing's growing. However, each follicle, there's so many, are putting off just the right amount of estrogen to tell the brain, hey, we're good, and they're actually not, because nothing's growing. And so, with that pattern, nothing ends up happening. Sometimes you can grow a lining, sometimes you really don't. So your uterus is stuck in this place where there's kind of old cells sitting there. Nothing's ovulating. There's no drop in progesterone to signal you to bleed. Occasionally, you may have spontaneous ovulation, and so that's where you can kind of get those irregular cycles. You can have anovulatory bleeding. So, the uterus, I guess for lack of a better way of explaining it, kind of overflows and you get anovulatory bleeds and you get stuck in this cycle. And then the ovary starts to get bored, I guess, in an easiest way to say it. And an abnormal LH signal starts coming down from the brain. And that LH causes the ovary to start producing androgens or male hormones. Mm-hmm. And then that's when you start getting testosterone produced instead of estrogen. And there becomes this balance between estrogen and testosterone that's really thrown off. And then that's where you're getting your male hormone symptoms like acne, male pattern hair loss, so in your temporal area, those sort of things.
Yeah, that is really good to know. That was a very, I learned so much in that explanation. I feel like that was a very, easy to understand way to break down, just what happens, month over month and year over year with PCOS.
Yeah, and, there are so many components because it is really an endocrine disease where there's just this miscommunication between the brain and the ovary. And so they're really, the communication is very dysfunctional. And the other thing, with PCOS, I do like to put patients on metformin. Sometimes we will put patients on metformin that don't have PCOS, but it is helpful because insulin resistance does play a big role with PCOS. Were you ever put on metformin for any reason or inequality?
Yeah, I was. I was put on metformin for recurrent pregnancy loss. I guess there is some type of study data out there that says that it can help to sustain a pregnancy or just regulating. Now I did early on in my fertility journey, starting IVF, I did take inositol, the powder, to just kind of regulate. I just had read so many different people saying that it was something good to take. And then at one point I guess I had told, my REI and they were like, okay, well stop taking that now.
Yeah.
Okay. But I think we have a lot of patients that do have, PCOS, that inositol is a good option for them, and can help to regulate, their insulin levels. But metformin, I think that's probably obviously it's prescription. It is, it can be prescribed by your provider, or it would have to be prescribed by your provider. And it has a long-standing history of treating this particular, issue with insulin. So, it's more regulated.
Yeah, and GI symptoms, a lot of people, have complained about with metformin, which eventually they should get better, but, stomach upset, diarrhea, sometimes that can prevent patients from sticking with it.
Right.
So sometimes we will titrate that dose up.
Yeah.
Did you struggle taking it at all, or?
It did make me sick to my stomach at first. And so, so the dosage that I was on, I kind of okay, I did that for a few days, not tolerating this well. Yeah. And so I did, like you said, titrate up and work my way up to the full dosage over, a couple of weeks. And that did help for sure.
Yeah. And so I guess to understand how metformin and myo-inositol helps, it's important to know, or I guess to understand insulin's kind of role and the impact on reproductive hormones. Now, not everyone with PCOS will have insulin resistance, but 50 really to 75% of people with PCOS will have insulin resistance. And so that's why we do kind of favor the metformin. Insulin, does a couple of things. It helps the body to use glucose and store the sugar. And so when you have insulin, it helps the cells to kind of uptake that sugar and use it for energy. What happens with insulin resistance is that those cells aren't really uptaking that sugar. And so really they're kind of saying, hey, there's no sugar here, we need more. And so, the liver starts to break down glucose to give more sugar. The blood sugar level gets really high, but the cells aren't utilizing it. And then the pancreas, meanwhile, is working super overtime to produce more insulin, and it's not utilizing that sugar in the blood. And so that's where you get those kind of high sugar spikes. And insulin also impacts the reproductive hormones. So it does. So your ovaries, first off, are already getting that abnormal LH signal from the brain to produce those male hormones. With insulin being so high, it actually stimulates ovarian androgen production even more. It causes the brain to make more LH, and so then on top of that, you're getting more male hormones, and it also prevents the liver from making something called sex hormone binding globulin, or SHBG. And so with SHBG, really the more you have, it loves to bind to hormones, so it binds to free testosterone. And any testosterone that's bound to this SHBG, the body can't utilize. So you're not seeing the effects of it, which is good. But if there's high insulin levels and the liver's not producing it, then you have more free testosterone that's kind of acting around the body, and it can cause worsening symptoms because you have more free testosterone. So where you get, again, acne, hair loss, extra hair growth on your face, and things like that.
And that's why more, like, some patients are going to notice those symptoms more than others. I would assume that if all of those, like, the perfect storm comes together, then that's when they'll notice those symptoms, kind of visualized on the exterior more than others.
Yeah, well, and that's why, diet, for one, is so important, because if you have PCOS, which is already kind of an endocrine issue, dysfunction on its own, and then, add insulin resistance on top of that, which we try and kind of combat with metformin, and then, if you are obese and have PCOS, that also plays a role and can worsen the disease. Fat cells make estrogen, or they make a form of estrogen called estrone, which can aromatize using the hormone aromatase, which just is a fancy way for saying that it can turn into testosterone. So now, on top of your ovaries making androgens, now you have fat cells also producing testosterone. And so obviously these are making these clinical symptoms worse. And because these fat cells are producing estrone, or this version of estrogen, the brain again is thinking, oh, I have follicles growing, there's no need to send on more FSH. And it's like these things that just compound on top of each other that are making it so much worse.
And hence the reason why it's so important to, let your OBGYN know, let your PCP know, if you are not having regular periods. And, I do love that. I feel like that most of the time, even when you go to the PCP, they're going to ask you when was the last day of your, or when was the first day of your last menstrual cycle, and try to keep up with that, and just making sure that it is regular, because it can affect, so many things, and there can be so many reasons as to why you're not having a menstrual cycle. Do you have, something underlying going on, or are you pregnant and you didn't know? I mean, so many different reasons as to why you may not be having a regular cycle. But it's really important to get to the bottom of that and see how it's affecting other systems of your body.
Yeah, and you bring up a good point about we need to rule out other things, like congenital adrenal hyperplasia, or CAH. We need to check thyroid, look at, prolactin levels. And so important that your provider is ruling out other things. And you did bring up, normal menstrual cycles. Sometimes people will think, because they get a period every month, that's normal. And sometimes, you'll get it 35 days, and then the next time is 20 days, and the next time is 39 days, and then the next time is 25 days. So that's not normal, right, that big of a fluctuation. Whenever I ask patients, I usually say, if I give you a calendar, would you be able to point within 1 or 2 days when your period is going to start? And if that answer is no, then we might be kind of leaning towards why not. And you brought it up too, diagnosing that there is, a way to get it diagnosed.
Yeah, I think that like just further investigation, no matter if it's PCOS or some other underlying issue, just doing some further investigation into like what is going on and why, and what's causing this, and if you're having symptoms from it, then finding out what the root cause is can help bring some relief to you.
Yeah, and actually the way we diagnose, because again, I will get people that say, I had a cyst one time, I have PCOS, or I'm overweight, I have PCOS, and there is a criteria that we do use to diagnose PCOS. It's called the Rotterdam criteria, and in order to be diagnosed with PCOS, you have to have 2 out of 3 of the things. So really what I look for the most, the hallmark, like we talked about, is the irregular absent periods. The second thing that you have to have, or 2 out of the 3, is hyperandrogenism. So meaning, a high amount of male hormones, and this can be diagnosed by either blood levels of either testosterone or DHEAS, or clinical signs of excess male hormones, so acne, hair on the face, male pattern hair loss. The third is polycystic appearing ovaries on ultrasound. And so they've actually altered this to also include an elevated AMH.
I was going to ask you about that. That was going to be my next question. Okay.
Yeah, so you have, obviously, remember, more eggs coming out of the vault, higher the AMH. And so with PCOS, we talked about there's this constant luteinizing hormone, or LH, stimulation that causes the thecal cells in the ovary to start to make the androgens, and these cells start to hypertrophy, and they thicken, and they cause a really thick central part of the ovary, and pushes those antral follicles out to the outside of the ovary. And so that's where you start to get that string of pearls look, and it just kind of, I guess, looks like a pearl necklace in the ovary. There's just a bunch of circles around the outside. Some people will also just use a high antral follicle count, but really in true PCOS, we do see that thick central part where you do get that ring of pearls. If you meet 2 out of the 3, you are diagnosed with having PCOS. Important to know, though, 8 to 25% of normal young girls will have a high AMH.
Yeah.
They will have, irregular periods because their body hasn't regulated itself yet. And so it's important that we're making sure that we're not misdiagnosing people with PCOS when really they're young. And a lot of these can be symptoms like acne, that they just have as a part of puberty.
Yeah, absolutely. A lot of like teenage girls are really into sports. And so, like there's a lot of different, they're not eating consistently. I have a teenager, like, I know, like, my husband sometimes will be like, how about let's eat a vegetable? And she loves vegetables, and she loves, like, obscure things that I feel like that most adults don't even like, that I'm just kind of like, oh, really? You really like that? But yeah, I mean, like, like chicken strips are like their best friend, like, all the, yeah, so, I mean, all of those things, they have active lives, they're busy, like, kids are like busier than I feel like they've ever been. They are constantly involved in different activities. And so those are really good factors to like take into account as to like why, if PCOS is not the reason, why they may have, some irregularities in their cycle, or it's just not like regulated yet.
Yeah. And, if you do end up getting a diagnosis of PCOS, there's a couple of other things that either we'll check or we'll have you follow up with your primary care. We talked about insulin resistance, because that could obviously make the disease worse. People can have high cholesterol with PCOS, so a lipid panel is usually a good thing to take. Sometimes we will check it. Sometimes we'll tell you to follow up with your primary care. If you're trying to conceive, we won't put you on cholesterol medication because it's not safe in pregnancy. So it's going to be a lot of diet and lifestyle management. You know, metabolic syndrome is a big thing, so you have to have 3 out of 5 things. A large waist circumference, an elevated blood pressure, high triglycerides, which is the bad type of cholesterol, low HDL, which is the good type of cholesterol, and a high fasting glucose. And so these are things that can be associated with PCOS that, again, just make the disease worse, and we would want to make sure that you don't have, so that we can kind of better manage the PCOS and the symptoms.
What would be your like number one thing or piece of advice that you would give to a patient that, like, regardless of whether they're trying to conceive or not trying to conceive, but they suspect that they have PCOS, what would be like your number one piece of advice to that patient or person?
Yeah, you know, I honestly would say maybe schedule a consult with one of us to kind of review ways that we can treat it. I've been pretty vocal about having PCOS on my Instagram, and I always get messages of, how do you manage it? And there's different ways. It's pretty multifactorial depending on your goals. So, you know, diet is one. Obviously, we talked about it, exercise, good weight management. So making sure that, and I could say this all day long, and I'm the worst because I'll drink a latte and then have Diet Coke all day. So, and ramen at night. So it's easy to say, but that's hard, right? To control diet. Vitamin D is another one. Everyone's low on vitamin D. And so usually I'm supplementing all of my patients with it, but especially those with PCOS. It is very anti-inflammatory. Metformin.
And how many IUs do you usually recommend? Like, as just I know obviously it varies, but like just as like a general go-to, kind of starting out.
So if you look at like a normal prenatal, it's like 1,000 to 2,000 IUs. I always tell people that's not going to do anything, because their levels will come back at like, so normally for fertility purposes, we want it 40 or above. I think normal is 30, but we want it a little bit higher for fertility. So if you're already low and not even in the 30 range, I'll usually say 10,000 IUs for about a month, and then I'll switch you down to 5,000 IUs. If you're already in the 30 range, I'll tell you, okay, start taking 5,000 just to optimize it to get to that 40. Obviously, we don't want it past 100. Some people are also on the injections of 50,000 weekly. It's hard for the body to absorb that much at once, so I do just like the pills. But I think 5,000, if you're unsure, is an okay start. Minimum of 2,000. Okay,
good to know.
We talked about metformin. So that basically is just an insulin sensitizing agent. So it improves the sensitivity of cells to the insulin, so we're able to utilize it better. Myo-inositol, you brought that up. The brand you're using is the ovacisitol.
Well, not anymore, but yes, that I did. Yeah. Ovacisitol,
That also kind of helps to improve insulin sensitivity. So, you know, sometimes if I have people that are like, nope, I'm not doing the metformin, can't tolerate it, the myo-inositol, you know, is great.
And I never had any issues with like taking that, being able to tolerate it personally. It never like upset my tummy or anything like that. It is a little pricey. That particular brand is a little pricey. But yeah, I mean, it's like super easy to mix up in a powder and like not in water. I don't recommend that, but maybe something that is a little thicker just because it gets pretty gritty, but it doesn't taste bad and it's easy to just down the hatch.
So yeah, that's a good alternative, or you could take them both at the same time. If you're not trying to conceive and you're not getting cycles, those endometrial cells are just sitting there and they start to get bored, and that can turn into endometrial cancer. And so usually a progesterone pill every 3 months for about 10 days so that you have a drop in progesterone to shed the lining is good, because again, we don't want those cells just sitting there.
Right.
So sometimes we could do that with progesterone, or we can do birth control pills, again, to get you to kind of shed your lining so that they're not just sitting there. And again, had I known that, I'm like, you tell me birth control, but you didn't say, oh, it's just sitting there so that you're at risk of endometrial cancer.
Right.
We're not just giving you birth control
This
to
is to
mask
keep you
these
healthy.
symptoms. It's to prevent cancer.
Yeah.
And that's so important. And again, that's probably on the provider's side fault because we're not, explaining that well. The other thing is oral contraceptive pills or birth control, they also increase your sex hormone binding globulin. And so, again, this is binding to that testosterone and decreasing the testosterone and free androgen levels. And it also decreases the production of LH from the pituitary gland. And that's what's causing the ovary to make androgens. So it's shedding your lining, and it's helping with those clinical symptoms of PCOS, so, the acne and things like that. The other thing that can help with acne and male pattern hair loss is spironolactone, which I am also on. It is a aldosterone antagonist, and it binds the androgen receptors so that those androgens can't act on your tissues. So things like acne, it can help with.
Okay.
But if you're trying to conceive, we don't put you on that because it can cause birth defects. So that's for if you're not trying to conceive. Now, if you are trying to conceive, really we're just trying to make you ovulate. Mm-hmm. Not everyone will need this, like you mentioned. PCOS can cause, poor egg quality, and it does actually have higher miscarriage rates. But, there are a couple of options. We do ovulation induction. You can do timed intercourse at home or intrauterine insemination, IUI. Usually we're using letrozole or Clomid to do this. Letrozole is really the preferred one now. Occasionally, if somebody doesn't respond to letrozole, you can have what's called refractory PCOS, and we will add the gonadotropins or the injectable hormones. I don't do this a lot because you can grow multiple follicles, which can put you at a risk of multiples, and so you end up with canceled cycles. So there's kind of a fine line there. If, you don't respond to letrozole, you're growing too many follicles with injectables, then we will recommend IVF at that point. So, there are ways to treat it, and then metformin is included. It is pregnancy safe, so we do use that as well. I think we covered a lot about PCOS and ways we can treat it and signs and symptoms. Is there anything you can think of maybe that we should cover?
I think that like you said, that even if patients are not, if they suspect they have PCOS, they can still come to us, even if they are not to a place where they're trying to conceive yet, so that we can, evaluate like their symptoms, we can evaluate their medical history, we can evaluate their hormone levels with the preconception testing. Obviously, you can go to your OBGYN and take our like list of recommended preconception testing, list off what your symptoms are, and then, let them know that, you're having irregular periods or whatever the cause may be that's causing you to feel like that you have suspected PCOS. We're happy, obviously our providers are happy to, investigate that for you. And then just come up with a plan to be able to like, if you're not, looking to conceive until 2 years down the road, like come up with a plan, to get, your body more regulated, and be prepared to try to conceive, whether that's, with us or at home or anything in between.
Yeah, and, like you said, managing it, making sure it's managed well, making sure you have a plan for the future. And hopefully this episode was helpful for, realizing what it is, how you get diagnosed, what's actually going on, and how we treat it. So, yeah.
Yeah, and I think that it's important, like, if there are listeners out there that have questions about PCOS, or they've found ways to cope with it and manage after diagnosis that may be helpful to other people, please let us know. We would love to share, either anonymously or not anonymously. It's up to you. To share with other listeners. We'll be happy to answer questions that you may have at cnyfertility.com/fertilish, or you can DM us on Instagram. or TikTok or wherever. And then we would appreciate if you could rate our podcast and tune in each week on Spotify, Apple, Amazon, wherever you get your podcast.
Yeah, and we will see you guys next week.
See you next week.